thank you very much. It's a pleasure to be here. I'm honored to be invited to give the keynote address. I want to thank Brad Peterson and Level 3 for allowing me this opportunity, and more importantly, I really also want to thank SimGHOSTS, Ryan, James, and Lance for putting on such a great event. And of course, I have to thank Russell Metcalf, who's really somebody I've been working with really for the last 2 years. And the Simulation Center, to me, is actually at the center of our healthcare environment right now, and it's going to change the dynamic, as you heard from Dr. Gold. We are using it extensively, and I'm going to get into some of that, and I'm going to explain to you how I see medicine changing. But right now, for me, medicine is at its most exciting time, and I'm going to get into a lot of that. A lot of that has to do with the healthcare delivery, the value added of healthcare. How are we going to add increased value to our patients over their lifetime? I think simulation is a key part of that, and the training of people is going to be crucial. And then I think the other aspect is 3D printing and how that's going to work. And I'm going to get into a lot of that today. But ultimately, as you've heard, it's all about teamwork. And we really don't in medicine do a great job of working as teams, and that is a dynamic that is changing dramatically. Ultimately, for me, this is all about having a good time. So if there's things that you guys have questions, feel free. I'm here to make sure that you guys learn. If there's things that you're going through that you want to ask, just raise your hand and I'll be more than happy to answer them. This is a very casual experience. And we don't want people to die, because then you're going to have a pediatric heart surgeon having to help you. So really what I'm going to get into more detail about is what is confidence and value, the benefits of simulation as I see it as the whole and how it really is going to be the center of medical delivery, how simulation for us personally has been crucial to our personal success, and I'll show some of that. And then how we're branching out as a group here in the Guerin Family Congenital Heart Program. I really have nothing to disclose other than maybe I had a little bit too much wine last night to drink, but other than that, I'm good. Ultimately, if you just want to look at the flow chart or how patients are looked at, they're at the center of our care model, which is fine. And there's all of these spokes that are coming in, and it's this spoke and wheel design. And it's worked very well for many years. As was pointed out, this is basically how medicine has worked. And some people might even argue that at the center of that is the physicians were the ones that would be at the center, and the patient was one of the spokes on the wheel. I think things are changing, and we have to look at that dynamic and really reevaluate it. And I'm going to get into some of that. But really, I want to talk about what is confidence. Confidence is the ability to do something you're trained to do.
William Lawson's. No rules. Great Scotch.
So what is confidence? We all have been trained to do things. It could be playing sports, having a coach show you how to hit a baseball, hitting a golf ball. But really, this is truly what confidence is. And I think it summarizes it. It's that quiet and assured feeling you have just before you fall flat on your face. That summarizes it. But we don't want to fall flat on our face. So we need to have something that allows us to build the confidence to be able to work as a team and deliver the best level of care possible. And how we go about doing that is really where I see simulation and training. We have to have a new paradigm shift. And all of you in the room are going to be at the center of that. And there's all of this technology around us. It's how are we going to harness that technology, get the people into a room and work well as a group. So I see this as a changing dynamic, and I want you to keep this in your mind as the talk goes on. So I think caregivers, whatever they are have to be trained, and there's an educational platform. We go through medical school, we can go to nursing school, we go to fellowships training, but I think the Sim Center needs to be then that gateway into the healthcare environment. And that would include into the hospital as well as the outpatient environment. And then that's going to allow you to get to the patient care. That's going to be your avenues into the patient care. Off of that, what we really need is good quality improvement in research. And we're already doing that for the most part in getting feedback to the caregivers. And it's done well in the hospital. And so we have that avenue. Where we don't do it well is quality improvement in research in the outpatient venue. And we do good research that helps society. You can see all of these companies that come out, innovation that occurs in medicine is incredible, and it's had an incredible input in our economy. And of course, the patient interaction with the family is so important. What is not happening is we need to have that feedback loop that goes from quality improvement and the effects on the patient back into the simulation center, as well as research to drive improved education and patient care so that you have better hospital care, better outpatient care, and ultimately better care to the patient. And ultimately, one of the other aspects is we aren't looking at quality improvement as how it's improving society, and that's this whole concept of value. How are we going to add value to the healthcare dollars over an entire lifetime, do better care, and reduce errors in the hospital? And then, of course, the family effect on the economy, I think, is a big thing, and that's this whole value, which I'm not going to get into because I think it's a complex algorithm. But what is value? And this is just looking it up on the internet. It's this usefulness, benefit, helpfulness, and then as a verb, it's to consider to be important or beneficial. So we have to look at things, and I'm going to show some of the value that I see, how the simulation has helped us with our outcomes. So there's clear value that has been added. But ultimately, when you look at value as just a quick thing, it's this perceived usefulness or desirability. And at Cedars, we've actually looked at value as a very important aspect. And this is value equals the highest quality of care and service. And that's in our mission statement right now. And we believe in that very strongly. And as physicians and caregivers, I think we've done a great job of that when we want to treat individual patients. We are excellent at adding value to that person's life. I don't think we do a good job of thinking about it from an economic standpoint, which is now this value-added healthcare and these ACOs that people are talking about. But how are we going to make sure that everybody gets treated the same across their entire lifetime? And then that gets into society. We want to treat the population and have great population health care. We want to know that if you go into hospital A or hospital B, you're going to get the exact same treatment. And it's going to be at this high, excellent standard. And the way, to me, that is done is when you bring in this quality and research. And again, if you go back to that algorithm diagram that I had, ultimately, the simulation sciences is going to be a crucial part of that delivery of added value to healthcare. So what is success and mastery? This has been talked about, and I don't know if anybody's read Outliers, but I have to tell you, it's one of the greatest books that I've read by Gladwell. And really, in that book, he talks about different levels of mastery that you get. And you can think about it in anything you do. From playing sports to playing a piano, from playing a violin. There's a time where you're very novice and you're not that good. You get to another level where you transition into a better thing and you have some confidence again that you can do it. And ultimately you get to this third level where you're an expert at it. And I actually think there's a fourth level, and that this is this ability to have total mastery and innovation. So it's the ability to understand how well something works. And if you want to think about it as from a movie, it's like The Matrix. The ability to slow down what is going on in your world so that you can deliver seamless health care or hit a golf ball 1,000,000 miles and somebody like, if you think about golf, it's Spieth and his ability to recover, and any of these great athletes or anybody who is mastered has this ability to get to that next level. We need to be able to deliver healthcare into that realm. So when you look at mastery, and people talk about this in different things, it's this 10,000 hours of work. So if you think about what Dr. Gold spoke about, we were all trained C1, do one, teach one, is the modus that most surgeons were trained on. Well, how are you going to get that 10,000 hours to master anything? You're going to be at that lower line. So most people are going to be at this lower line of, putting in, and you're basically just a novice. Somehow we need to be able to accelerate this learning curve so that everybody within the healthcare environment is going to become a master and get those 10,000 hours. So how do we do that? To me, it's that gateway into healthcare has to go through a simulation center where you're allowed to make mistakes, but it's working together as a team. You have to not only master the ability to cut and sew and have technical skills. If you're thinking about a surgeon, you actually have to be the captain of the ship. How are you going to make sure everybody else is doing their job? How are you going to learn to communicate? So when you look at training, we might do 10,000 hours of training where we learn the skill to do coronary artery bypass grafting, taking out a gallbladder, intubating a patient. But have we learned the skill to harbor the resources of everybody else on our team? So you want to be able to see how are people going to respond in a very precarious situation. And the thing is that most of these bad events don't occur every day. So how do you train for that? So we're going to get into some of that. But first I want to talk about the skill and this is one of my favorite topics. So I always put this in talks. So this is a little bit of a digression, slightly, but it will play into a lot of what we're going to talk about later. But ultimately, in 1944 is when congenital heart surgery started, and that was the ability to operate on children that have a heart defect. And it was really started by Helen Taussig, who was a pediatric cardiologist at Johns Hopkins, and she had this blue baby clinic, and she followed these kids and wanted to figure out ways that they could be treated better. Alfred Blaylock was in Nashville at Vanderbilt and ran a lab, and he was a prominent surgeon at the time. And Vivian Thomas, who's the key character in all of this and hasn't got the credit he deserves, but if you're very interested in the story, I would watch this, something the Lord made by HBO Films. But Vivian Thomas was a carpenter who in the 1920s and 30s, during the savings and loan disaster, lost all his money, and he was actually saving up to go to medical school. And because he lost his money and the economy collapsed, he actually lost his job, and he ended up having to go work for Alfred Blaylock. And he worked with Alfred Blaylock as a janitor, but he ran his research lab. And in that research lab, he was able to develop things like for patients that had bleeding how are you going to treat shock? And he developed a lot of protocols that are used by the U.S. Army, but again, the person who got credit for that was Alfred Blaylock. Ultimately, Alfred Blaylock went to Johns Hopkins to become the chief of surgery, and he took Vivian Thomas with him to be his lab manager. Again, when he was at Hopkins, he was a janitor. While he was there, Helen Taussig came forward and said, "Can you do anything for my blue babies?" And Alfred Blaylock went to Vivian Thomas, and Vivian Thomas developed a surgical procedure. And he developed a surgical procedure as well as all of the instruments. And it's interesting, most of these instruments we still use today. And he was a guy who had incredible vision and an ability to see into the future. And so ultimately, they did this surgery. And the blue babies was really from Tetralogy of Flow, and I'm sorry for some graphic video, but this is what we do nowadays. And so Tetralogy of Flow is, you have a hole in the upper chamber, the atrium, and then you have a hole in the lower chamber, and then there's a VSD, and then you have obstruction of blood flow into the lungs. So we need to correct that. And in the day when Vivian Thomas in the 1940s, what they decided to do just to increase the blood flow into the lungs so the kids weren't blue and they could be pink, is they actually made a bypass system and they put a shunt. Nowadays we can do this full repair, but we still do that same procedure that Vivian Thomas came up with in 1944. And so what we'll do is we'll close this VSD here and open up the outflow tract to the lungs, and that gets closed with a Gore-Tex patch. And then ultimately we open up the outflow to the lungs, and then you have free egress of blood to the lungs so the kids aren't blue anymore and will have a normal life. So basically that first operation and things that we take for granted nowadays started with Vivian Thomas. And this is Vivian Thomas standing behind Alfred Blaylock, and he was the only one who could stand behind him because he's the only one who knew the operation. And he would sit there and tell him, okay, this is what you're going to do. This is the step by step. And ultimately around this table are two very prominent cardiac surgeons. There's Dr. Longmire, who went on to UCLA to start the cardiac surgery program and transplant program, which has become one of the premier programs in the country. And then Denton Cooley, who is one of the premier cardiac surgeons. And they learned their skills from Vivian Thomas, but ultimately, if you think about this model, Vivian Thomas was the captain of this ship. He controlled that room. He was the one who was directing how everything was going to happen, and everybody had respect for him. And that's a crucial part of the system. And then ultimately in '54, these first repairs on bypass were done by C. Walter Lillehei, and this ultimately started the era of where we could start operating. But we learned the skills, but we never really learned how to work together. So now I'm going to quickly shift gears and talk about American football. And I've put this in here so that people can understand the video that we're going to watch. So ultimately, there's an offense and a defense, and there's 5 players that can go out on a pass play. And you have to have the other 6 people have to be behind the line of scrimmage before you can make a pass play. And then the defense has to line up to cover those people. Does that make sense? Okay? The reason I put this slide in it is I showed the video and then some people said I don't understand football. So, that's the quick gist.
Hey.
So that's, the Ravens were killing the Patriots in the AFC Championship game last year.
Do what you're supposed to do. It's just about doing our job.
Shane Vereen declared himself an ineligible receiver at the line of scrimmage, but split out wide of the formation. Technically a lineman, Vereen had to stay behind the line to be legal. Conversely, tight end Michael Ho'omanawanui lined up as the 5th lineman, but was really an eligible receiver that Baltimore didn't account for.
They pulled out every trick play. I mean, they threw a lot of different formations at us. You know, guys eligible, guys ineligible.
Did you guys practice that, or did you just dust that off? Where did it come from?
Man, that's just something they just drew that up in the dirt on the sideline, and we went out there and executed.
Are you serious?
I'm dead serious.
Wow. It's just about doing our job.
Ultimately, what that shows is you have 2 teams. One team that was really prepared to the point where they were able on the fly to come up with a novel way to beat one of the best defenses. And in that game, right after they put that play in, Baltimore could not figure out how to stop that play. Every time that first person you saw, who was the top defensive player, went and guarded the ineligible receiver. And they took the best defensive player out of the game. And if anybody knows anything about Bill Belichick, that is his crucial tenet. They're going to take their best player out of the game. And they were able to do this on the fly and basically make a team that gelled to work well. And then conversely, when you think about Baltimore, they were very confused. And when you watch the video of the game, Harbaugh was going crazy, yelling at the referee. The players totally lost their ability to play as a team instead of figuring out the problem. That is medicine in a nutshell. We need to be like the Patriots, which we don't want to do Deflategate, I get that. But we want to be able to harness that ability to draw up a play in the sand that's going to work and win the game. And that's simulation. So ultimately, what is simulation? And this is a great paper from Hopkins looking at simulation. And it really looks at during an arrest and how we can improve the communication and teamwork within a healthcare environment. And it has some serious tenets, which I think are very important. The first is situational awareness. It's this shared cognition. So if everybody is on the same page and understands this is the information that is before us, we as a group are going to make a better decision. The Patriots did that. They were able to say, okay, what are we going to do to beat this team? Okay, here a play is, and everybody executed it perfectly. Whereas Baltimore had no situational awareness. They couldn't figure out. They ran that play 10 times in the game, scored 2 touchdowns on it, totally changed the game. The coaches, the players can figure it out. You needed this flattened hierarchy. So you needed a clear dissemination of the plan and have less levels of management. So you want to have the leader making decisions directly to the ground troops, and that's what happened in that play. You need to be able to report back, be able to say, okay, I'm going to do X, everybody understands that, and there's got to be this communication style that is very important, which is this closed loop communication, acknowledging what is said, executing. When you hear that video, everybody knew that Ben Vereen was an ineligible receiver, except for Baltimore. And then this critical language. We really want to know, how are we going to communicate from one person to the next person? What is the standards that we're going to communicate? And if you're doing it on the fly, you're going to have many mistakes. And you need assertive communication. They talk about this in Outliers with the concept of plane crashes occurred because there was deferential discussion. Korean Airline had one major plane crash in the 1980s because the captain was given such high priority, whereas 747s had to be flown by 2 pilots. But in the Korean culture, it really was where you were on the hierarchy scale, and it created multiple crashes. And if you read the book, some of them are unbelievable. Like the co-pilot knew that they were going to crash into a mountain, but he didn't want to say anything. He would rather die. So you need to have people who understand that you have to have non-deferential discussion. And it's very difficult unless you simulate it. I can tell you, I read that book and I've become somebody who speaks in command in very critical circumstances. And man, it puts people off. And people have to get thicker skin, but you have to understand you have a patient here. So if you can do it in a simulated environment, then you go back to a debrief, which I'll get into. You're going to change the dynamic. People are going to know what to expect. You want to be able to expect the expected. And you need to have flexibility and trust and understanding of, okay, these are the scenarios, how are we going to make it better? And then workload management is a crucial thing. If you're relying on one person to do all of the work and make all of the major decisions, it's going to be a major problem for the team. And then ultimately, debriefing is a crucial element and leads to higher performance because you're able to go back and discuss what's going on. So for us, I want you to see this video, and this is about Sullenberger. And the key element in the
1539 hit burst to lost thrust on both engines, returning back towards LaGuardia.
Got emergency returning. Which engines? He lost thrust in both engines, he said. Got it. Can I get him in for runway 1?
We can't do it. We may end up in the Hudson.
I think he said he was going in the Hudson. The story of Sully Sullenberg and the landing of that plane on the Hudson River goes a long way to explaining why simulation centers are needed. As we all know, the plane lost power shortly after its takeoff, and he magnificently harbored the resources of his crew and was able to land the plane on the Hudson River. All the people on the plane were spared injury, and it was a miraculous success, which could have been, under other circumstances, a terrible tragedy. When he was asked, Captain Sullenberg, had you ever done this before? He says, I've done it many times in a simulated environment.
Here at Cedars-Sinai, we have the Women's Guild Simulation Center in order to create an environment which simulates real-life clinical situations. And this allows us to train nurses, doctors, technicians, so by the time they do go to the emergency room, they're well prepared, they've been trained in the latest techniques, and the latest techniques have been literally at their fingertips.
So that's how we got involved in the Simulation Center, and it started with this baby here. So we were doing a operation on a premature child who had complex congenital heart disease with a team that had never worked together before. We wanted to figure out how are we going to communicate well as a group. We had just started a whole new program here at Cedars-Sinai. So we went to the Simulation Center, worked with Russell Metcalf and his team to develop different scenarios that we were going to stress our team and do all of those things about improving communication, allow non-deferential discussion, and see how we would respond. You know, and we worked in the Simulation Center for about 17 hours. But what we did that was a little bit different is that we actually looked at the holistic approach. How are we going to care for this child who ultimately did exceptionally well, and we didn't have any problems, which is what our hope is. But what we were able to do is take a child, operate on them in the simulation center, stress the OR team, and then take them to an ICU and stress the ICU team and see how the two teams work together. Because that's a crucial thing, and there's a whole thing about handoff, which I'll get into. But how are we going to take the care from one venue to the next venue, and how are those two teams going to work well together is one major problem, but each individual team has to work well. So it's like having your offense and your defense. So ultimately we were able to do that by working through these scenarios, and it's really galvanized our team because you're able to do things in a simulation center that you hope you never see. So as you heard from Dr. Gold, process improvement is a major problem in healthcare. And I think it's this team dynamic and communication styles are so important. Ultimately, to err as human, it was estimated that 98,000 Americans die each year because of broken healthcare processes. Harvard Business School just reevaluated that analysis, and it's 400,000 people. So 400,000 lives are going to be lost. So you go back to confidence and value. How are we as medical providers allowing that to occur? That's staggering to me. It's staggering that we haven't developed systems. We give great value again to the individual patients, but not across the population. So we have to change that dynamic, and that's why that diagram I had is so important, because clearly getting health providers into the hospitals and outpatients to improve processes, you're going to want to go through a simulation and improve training. And we have to revamp the way we do medical education. And so a lot of that is communication styles. How are we going to look at these, what are human factors? How do we work well as a group? And so this was a consensus statement from the AHA that was published in 2013, looking at patient safety in cardiac operating rooms. And what they found is that minor communication failures lead to significant adverse events. And it becomes a compounding thing. And you think about that in everyday life. I mean, I talk about some of this as like a marriage. I mean, if, you know, I have 3 kids, I have a 16-year-old, and man, they are awesome at dividing the mother and the father. Anybody who has a kid. Can I go to the mall? Sure, you can go to the mall. Did you talk to your mother? Oh, I already screwed up, right? Because then she's going to use that. She sees the crack. We as a team need to be able to not have those cracks. We have to know how each other is going to work together. But really, there's these 6 C's, which I think are crucial. And it's communication, cooperation, coordination, cognition. This collective knowledge is so important, and shared understanding is so important. So if you've already been in the trenches with somebody in a simulation where some kid arrests and you saw how the team works, you're going to have so much more confidence. Think about Sullenberger in that plane. I mean, his voice. I mean, he knew he was going to land that plane in the Hudson River without a problem. And when you listen to some of his communications and some of the things that he said, is because he really, as Dr. Gwertz pointed out, harbored the resources of his team. He knew his team was going to work well. He knew that the flight attendants, who are the safety operators of the plane, were going to prepare that plane and they were going to land safely. If you don't have that ability to know your team's going to work in a critical junction, you're going to make mistakes, and 400,000 people are going to lose their lives. And then you need to be able to have conflict resolution. Everything's not going to be perfect. I don't always agree with my wife. She probably thinks that I should always agree with her. But we need to be able to figure out how we're going to work things through, and then coaching is a crucial element of that, and that's this team training. So we already had things in place to improve our communication. And there's a 4-pronged approach, but how are these things going to be worked into reality? So we have what are called pre-brief, where I give a whole rendition of what I expect from the surgery, every step. We have a team huddle the day before surgery, which was really started so that we didn't need to do the timeout in the operating room while the kid's asleep. And that was really done for JACO, for the correct patient, the correct surgery, and the correct location. So we were able to do all of that, but we were able to have non-deferential discussion in a conference room, iron out our differences, and have what I call goal alignment. So we were all going into the operating room. But if you've never done it before, how do you know it's going to work? And then we would do a post-huddle where we would review what we had discussed in the pre-huddle, and then we would do a team handoff. So this is just, not to be busy, you don't need to read all of this, but this is what that email looks like. So it sets the stage. It allows for people to basically flip the classroom and have an understanding of what is their personal goals going to be. And then we do this team huddle where we read our goals and post-huddle and align to get alignment. And then we do a team handoff, and that's to be efficiently and timely and accurately change teams so that everybody knows what's happened. You link all of the dots, and you basically allow to track any issues and see how your patients do. And so you're able to transition from one team to the next team. So we had these communication styles already in place, and really what we were looking to do was make sure they implemented well here. So before we did that baby, we actually went through this in the simulation. This was a crucial part of the simulation. And then it allowed us to set up, because you have this flow of information, what is your communication? How are you going to communicate at the back end? And that's the debrief, which is the crucial part of any simulation, and I think any team dynamic. I mean, you think about the football, you heard those players talking about it. They do debriefs all the time. Like, how are we going to, Baltimore, I'm sure, has had about 1,000 meetings. How are we going to make sure this play never happens to us again so that we don't lose the game? So why simulation? So for me, the best simulation is it doesn't suspend reality. You want to be able to communicate during the task, and I'll give an example of how that is so important. You want this environment that's controllable and that you're going to be able to change the dynamic in the room so you can test that communication, and then crucial is the debrief. So virtual reality and fidelity, and so this is from the process of simulation that really, from 2013, is there's the real environment on one side and virtual environment on the other side, and somehow we are mixing the two. And you think about the digital age, we're tweeting pictures and all of that, that there's this digital footprint that is out there. And I actually look at it as a circle. And I think this is the crucial change in dynamic that gets into how are we going to do that making the simulation and training different. So there's the make-believe, that is crucial, and reality. And then there's augmented virtuality and augmented reality, and they're one and the same. And you really want to have the reality being able to feed back to your simulation center, ultimately to improve that virtual augmented life in a simulation so that you can train and test. And then it goes back to reality, so you do the same procedure. You should be always improving. And that, in quality terms, is these PSR cycles that people talk about. So it's the ability to come back and have this concept of this virtual reality. So you want to bring the tools that you have in the simulation center to your clinical world. And it's been shown. I mean, this is a paper from 1992 with military flight simulators and a meta-analysis looking at outcomes. And basically, people who did simulator training had better outcomes and better flight scores than people who just learned on a plane. The one fascinating thing is that motion versus no motion really was a negative, because the simulations in those days didn't have the fidelity that you need. You weren't immersed totally in your day-to-day life, but it was important. It ultimately has become important if you think about Sullenberger and what he was able to do and how he could train and have that confidence to be able to land that plane. So looking at coal mining, which is one of the most dangerous, accident-prone jobs, they looked at how could we improve simulation in Poland, and this is in 2015 in safety science, and they really did simulation using different types of simulations and really found that it gave people that orientation to space and knew where they needed to be. With the improvement in the motion, there wasn't really increased, it was thought to be similar. But ultimately, the key element is these participants got the confidence that they could do their job better. And so just after training, they gave it a score of 6, and then 3 months later, they gave it a score of 6. So out of a scale of 10. So they really learned, whatever their skills they learned in the simulation environment, helped them do their job to the daily basis. I would argue that they needed to have a feedback loop and then figure out where they were having errors and do more. But more importantly, what ended up happening with all of this is it helped them work as a team and have a safer environment. And they really, all of them strongly believed that was a major change. They felt confident that their co-workers were going to work well with them, and they ultimately felt safer. So to me, it's all about task-dependent communication. So you think about Sullenberger. His 2 engines have gone out. He's trying to figure out in literally like 5 seconds, what is he going to do? Can he go back to LaGuardia? No. Both engines are out. He's going to land in the Hudson. He has to make sure that everybody on his team understand what has to happen and prepare the crew, prepare the people on the plane, and fly the plane. And when you listen to his voice, he is under so much control. He is so confident that this is going to work because he believes in his team. He has done this thousands of times. It's no big deal to the guy. That's what you want. So if you think about it, how do we do this? Pat your head, and actually Ken Catchpole made us do this once, and it's absolutely impossible. Pat your head, rub your belly while reciting Proust. You can't do it because you haven't thought about it. You haven't trained in it. It needs to be hardwired. You have to understand what your individual deficiencies are while you're communicating. And you have to be able to, in that time, prepare for the unexpected while having this seamless communication. And I can tell you, when we use the simulation center, what I find is that our team is so much more engaged in the simulation center than they are in the real world because they know something bad's going to happen. It's like the haunted house. So there's a whole science behind that I'm very fascinated about. But right environment to me is, we have a great simulation center, and you're going to be able to see that later today. We really want to strain the communication style and then learn from it. and then develop the right tools and have the right thing. And I'm going to explain one of the things where we're moving in that direction and using technology. So ultimately what we wanted to do is we wanted to strain me, because I'm that captain of that ship. I'm Sullenberg, and I wanted to strain everybody else that's working with that baby. So we've gone ahead and made with Syndaver a heart that you can operate on. And so that picture that I showed with the hole in the heart, we have a heart that you can operate on, close it back on, go on bypass. And then in the mechanics of this 4-month-old kid, we're able to change the perfusion parameters. So it strains anesthesia, it strains perfusion, and it strains the nurses. And we can change those things by you guys understanding what we want to do clinically and affecting a change at that moment. So we have this very high fidelity system, and this is just a schematic diagram of how we put it together. And so this is the actual first rendering of the heart, and we really wanted it to be realistic. And these materials you're able to cut, suture back together, and reuse them. And so we changed the orientation, we looked at pictures in the heart, and we really, through different prototypes, were able to come together with, you know, a very good-looking heart. I mean, this looks realistic, and really our next step is how can you get it so it can beat, to really add to that next level of fidelity. And so ultimately all of that
ready to go?
works very well.
We're going to be operating on a 4-month-old that has a heart the size of a walnut.
A tiny heart, a life-threatening hole in it. It needs to be repaired quickly. A complex surgery that requires a large group of doctors, nurses, and specialists.
We're all ready? Okay. Do you want to get the lines up?
But no matter what happens in this OR, the infant patient is in no danger of dying. He's actually a high-tech model.
This baby is really a first of a kind where you can actually operate on this baby.
Dr. Alistair Phillips says it looks just like the heart of a human child. Even the mannequin's skin can be operated on. But unlike normal surgeries, the doctors and nurses welcome problems like failed equipment or patient complications. It's a chance to deal with challenges before they're life-threatening for real.
We're having problems right here. The problem, you can see all the volume in the heart here?
Mm-hmm.
So we're trying to get this under control. But we've been able to put ourselves through very difficult scenarios that otherwise might be life-threatening and respond very effectively.
Using the same medical equipment that'll be used in a normal OR, the simulation center can test doctors and staff with a variety of scenarios, like childbirth, ER visits, and a host of surgical problems.
I think this is going to change medicine. I think this is going to become the standard of training for physicians and teams.
And that, to me, is the crucial thing of what we want to do, is we want to stress the team and really allow the team to learn how to communicate. And this is the future of medicine. This is coming. We do this every day. And this is just the example. We have this infant. We go to the operating room. We ICU. We do a handoff. And again, if you look at this picture, this is one of my favorite pictures. We're in a perfect circle. And I was explaining this earlier. The reason we're in a perfect circle is because everybody knows things going to happen and everybody wants to listen and have no communication. So you think about it, everybody's thinking about each other on the team, and the only way that everybody can be close and hear the same thing is in a circle. That does not happen at the bedside. And then we do scenarios in the ICU, but it's all run with, our control room, and having the scenario built beforehand and understanding what we're trying to accomplish, and then doing the post-brief is crucial. And debriefing is crucial. It's understanding why, and it's really allowing a comfortable communication style that people don't feel intimidated. So you want people to evaluate themselves. And I can say, the first time I did this scenario, I actually made several mistakes, and I realized it during the post-brief, and we went through it, and I was like, oh my God, I'm the guy who didn't explain X or Y, and I actually put the scenario together. But I had this lapse of communication that was crucial and would have ultimately affected a child if the scenario that we had put forth occurred. We wouldn't have been prepared for it because of my poor communication. So you're able to have internal review, but you need a leader who can run that, and the debrief is crucial. And so that, to me, is this critical role of simulation. It's the patient care. You're going to have a debrief that's going to allow you to run your simulation. Your debrief in the simulation center is going to allow you to have better patient care that's going to keep that circle going, and you're always going to improve. Everything's going to get better. And so I do see this expanding role for simulation, and it's not only this ability to practice as a team, but it's also to practice and innovate. And that's what I'm going to get in for the last, hopefully, 10 minutes, if I'm not too far behind. But ultimately is to do these dry runs on very complicated procedures. And 3D printing is a crucial part of that. So we've actually purposefully linked our 3D printing with our simulation center because it allows us to utilize the team and make different mannequin parts if we need them. But it also allows us to then do simulation of a basis of a procedure. And I'm going to show one of the procedures that we do here. So pulmonary valve replacement, if you remember from that first video, is very common in Tetralogy of Flow. So because we've cut out that pulmonary valve, if you remember where there was the patch, the blood backs up into the right ventricle, and ultimately 85% of people will need to have another operation. About 15 can have this percutaneous approach through the groin. But I think most people are going to be able to have this perventricular approach, and it's something that we do here, and we do it minimally invasively, and we work as a team. So we have a cardiologist and a surgeon working together. So this is just the gold standard, what is done everywhere else. You have to do this reoperation, and you basically are just putting a valve right in that patch that I had shown in the first video. And we suture in a new valve, but they have to go on bypass. They have a major incision, and they have a lot of pain afterwards, usually in the hospital 5 to 6 days afterwards. It's a big cost. So we looked, is there a way that we can do this without having to open up their chest? So we turned to 3D printing, and we thought, okay, let's print the hearts and see if we could figure out a way to do this. And so 3D printing allows us to simulate the surgery. It's been used in a lot of things. If you read anything in the media, this is somebody printing a new earlobe for somebody that they put in plastic surgery. There's femurs that are being made. Yeah. But here we are simulating the surgery that we're going to do minimally invasively. And we're putting different stents in to reduce the size of that outflow so that we can put a covered stent in. So this is all of us working together, literally on our desktop. And you can see these different stents are being blown
part of
up.
it is the big ones.
We're trying to figure out how the angles are going to be affected.
So I'm not worried about that.
Using the 3D printing is
doing
exact rendering of the patient's heart. So the key element of that is that we want to ultimately put this covered stent in, and we want to reduce this irregular shaped outflow. And so we do that, and then you get that landing zone, and you put the stent, and we can do it through a 2-inch incision. And this is it being done, and we put the sheaths right into the heart. But if you look at that video on the right, it's exactly like what we did on the desktop. We had the confidence that we could go in there and it was going to work. And then we put this covered stented valve in, and it's done through that approach through the base of the heart. And ultimately, it works very well. So we've done about 20 of these. But the only reason we're able to do this is we have that mastery as a group because of simulation. It's this circle of life. And so it is a changing dynamic. And again, I'm going to get back to this. This, to me, is the caregivers, and I would even put the simulation center as a bigger element in the future. And it has to be your entree into the hospital and outpatient to affect change for the patient, and ultimately have that feedback loop from quality improvement and research and improve the patient outcomes. And so we were able to improve the outcomes. This is just the patients, the initial patients, they all had severe leaking of the valve. At the end, they all had trivial leaking. They went home within 1 to 2 days. They didn't have to stay 6 days. They didn't have a big incision. And then just being able to improve our communication prior to doing basically an enhanced handoff, we've decreased our flow disturbances in the ICU. And more importantly, we've decreased our significant clinical events at 6 hours post-operatively from about 88% to 23%. And our time to do these handoffs has decreased significantly, as well as those clinically significant events. So it's had an impact. We've been able to do high-risk surgeries with very good outcomes. And I think a lot of that has to do with simulation, having better team approach and communication. So we've reduced our blood draws. So this is a traditional ICU, and you can see how many blood draws, 14 plus all of these. We're able to do it with about 6 to 7 blood draws for a similar procedure. So I do think it's important to add value. You got to work as a team. That's why medicine now is so exciting. It's the best team sport. And hybrid approaches and this concept of working with different groups is crucial to improving the value and improving confidence in the team. You have to have goal alignment, and I didn't really get into that, but that's the ability to communicate what is our expectations from the microcosm to the macrocosm. Simulation in a high fidelity center where you don't suspend reality is crucial, and you have to really test the team communication and stress it and strain it to really improve ultimate outcomes and give that confidence and ultimately improve the value of healthcare. So situational awareness to me is crucial. You have to think about landing a plane in the Hudson River. He was able to figure out exactly what was going on. His team knew what to do in a split second with very little communication because they relied on each other. And you have to have a very flat hierarchy. You have to have this critical language in communication and a style that the team can respond to. And ultimately, that feedback loop is debriefing to me is crucial. So we've actually taken that, what all of you do in debriefing for simulation, and do it in our patient care. The next morning after surgery, we will discuss what could we have done better. And then we take that information back to the simulation center. So I think medicine is an evolving field, and I have to say it's probably one of the most exciting times in medicine because of everything that I just spoke about. But it's this ability to work as a team, innovate, have the right environment will lead to decreased impact to our patient, improve long-term quality and quantity of life, and ultimately lead to better lives for everybody. Well, thank you very much for allowing me to speak. And if anybody has any questions, I'll be more than happy to answer them. Somebody's got to have a question. Which one? The 3D printing? Yes. And then the other heart model was actually designed by this group, Syndaver. And Syndaver has, polymers that you can operate on. And that first model was developed by, I think, casting with different plastics.
Was the team set up for 3D modeling and this 3D printing already before you guys came into the space? Or was it, hey, we've got a new need, and then the team had to go and kind of investigate the technology and bring it together? Because I know there's tons of 3D printers out there, and just that knowledge for a simulation program in and of itself as a department, there's so much going on there. So I know there was a lot of learning that had to take place.
It actually was a fascinating, we were looking at 3D printing to do this procedure, and then it turned out that the simulation center wanted it 3D printing to build basically an arm so that people could practice putting IVs in instead of having to buy those really expensive arms, which I don't know the total details, but the simulation people who are here can explain that. And because of the relationship that we had, it was really this aha, wait a minute, we are doing the same thing. And Russell and I were talking, and he was like, oh, we're looking into 3D printers. I was like, we want a 3D printer. So then we realized that that was the exact space that you wanted, and we had, team cognition, and we put our heads together, so to speak, and came up with what we thought we needed, and now we have 3 3D printers that print different things. Yes? So the question is what do we do to flatten the hierarchy? So ultimately, it's about communication. The first thing that we did is nobody's allowed to be called doctor. We only go by first names. And so the first day I got here, I went and there was an older ICU attending who introduced himself to the nurse as doctor. And I said, no, you're Harold, that's Jane. Jane, meet Harold, Harold, meet Jane. That's from, and I think it's top down. So it really gets into that was what happened with Korean Airlines, is you have to eliminate that artificial hierarchy. And then you have to communicate, and you have to allow an open communication style. And I think it's difficult for a lot of people, especially younger people, to understand that that's a reasonable thing to do. And it's just persistence. Yes? Run, Ryan. Get those knees up.
Hi. I'm part of a school of nursing and developing the faculty. My question to you is, you had to do that more than once. And did you call them in on their off days? Did you pay them? All those practical issues, please.
Yeah, so we called them in on their off days. But ultimately, you're exactly right. I think why that picture, and I'll actually go back to it because I think everybody has to understand. So this here is a crucial part of your healthcare delivery. And I think we were fortunate because we were able to go to the administration and say, this is so important to us, and we believe that we need to do this to improve the outcome of the patient. And they were like, yeah, this is going to cost us some money. However, it was beneficial, and it's actually persisted as a result because our outcomes have been so good. So it's a cultural change, and it's, again, adding value. It adds so much value to bring in people to train. So you think about, total artificial heart is happening. We do a lot of those here, but if you're trying to bring in a new surgical team and you're going to do that on the fly, it's not going to work well because you're not going to know the system. So if you want to make sure that that outcome is going to be the best, you really want to invest in this. But the investment is beneficial because you're going to improve the value of healthcare. You're going to reduce your costs. So again, I think that's just changing that economic picture of healthcare delivery, which is happening. And that's why it's another exciting time, because I think there's this opportunity now. Hopefully that answered. Yes?
You know what? I don't think I'll need the microphone, so I'll just say it up. But one question, it seems in your talk, things like 3D printing and this kind of preparation technology, are you guys using that as a way to control post-operative costs, complications, blood, all that is very expensive after surgery? It seems like this kind of method would basically eliminate downstream expenditures, healthcare delivery, by making the procedure go right the first time. Is that something you found here?
That is a goal of mine, and it's actually quite interesting because I put the blood draws up there as for a reason. It actually turns out that hospitals like you to draw blood because because it's actually good for reimbursement. However, it's not good value. So I personally was in the hospital and for a week and in the ICU, and I think every day they would draw about 50 cc's of blood. And it was horrible. Like, he'd say, what are you doing? And ultimately, it's all about the patient, and it's changing that paradigm to what is the best value for society, the economy, as a whole. And we have to look at population and holistically what's going to be better. And that's the change that's happening right now. And that's why it's, I think, very exciting.
Amen to that. That's great. Big thank you for Alistair for